All right, let's talk about the innervation of the ITG and rotator cuff muscles. And as we do, we're going to answer a few questions like what nerves provide innervation to the rotator cuff muscles, what nerves provide innervation to the intertubercular groove or the ITG muscles, and then what are the clinical presentations of injuries to these nerves. So we're going to start with the suprascapular nerve. And again, we have an image of a right brachial plexus here. And the suprascapular nerve is coming off of this portion right here, the upper or the superior trunk. And so we can see we've got it labeled here. So the C5 and C6 ventral rami form this upper trunk, and then the suprascapular nerve is coming off of that. And the suprascapular nerve, it gets its name because it goes through this notch right here. So you can see we've got an anterior view of the right upper limb. We've got the coracoid process here. We've got the clavicle. This notch is on top or kind of the upper portion of the scapula. So we call it the suprascapular notch. So the nerve that goes through there is the suprascapular nerve, and that's why it gets its name. And again, when we switch images, we've now got a posterior view of the right upper limb. So the suprascapular notch would be this guy right here. And so that nerve will come through this notch, innervate the muscle that is here above the spine of the scapula, and then the nerve will also kind of like snake around here to also innervate the muscle that is below the spine of the scapula. So if there's any impingement in this notch, we might see a clinical presentation for the suprascapular nerve injury of a diminished ability to initiate glenohumeral abduction, as well as a diminished ability to externally rotate the humerus. And that actually might present as an internally rotated humerus since they can no longer externally rotate or they have a diminished ability to do that. And then with a suprascapular nerve injury, we will not see any loss of cutaneous sensation. So now let's figure out what muscles will cause this clinical presentation. So looking at a muscle that might initiate glenohumeral abduction, it looks like this muscle here above the spine of the scapula in the supraspinous fossa. It's going to come around, insert, and then help to initiate that abduction of the humerus. So that is the supraspinatus muscle. It initiates humeral abduction from the first 0 to 15 degrees, and it is innervated by the suprascapular nerve. And then looking for a muscle that would externally rotate the humerus, we have two options here. This muscle in the infraspinous fossa, if it was to shorten, it would externally rotate the humerus. Same with this smaller, more round muscle that would also externally rotate the humerus. So the one that is innervated by the suprascapular nerve is the infraspinatus muscle, so this guy right here. And again, that's going to externally rotate the humerus, innervated by the suprascapular nerve. And just to get a second view of these rotator cuff muscles, we've now got a lateral view. So we've got anterior here, because we can see the coracoid process. Posterior over here, we've got a little part of the spine and then the acromion. So the infraspinatus muscle, you can see here, when it shortens, it's going to externally rotate. Supraspinatus, it's going to abduct the humerus. Okay, so let's move on now to the subscapular nerves. We have a couple, and these nerves are going to be coming off of this portion here called the posterior cord. So the first one we have is the upper subscapular nerve here, and then we get a little bit of a break, and then we have the lower subscapular nerve. So these two nerves, again, coming off the posterior cord. Injury to the subscapular nerves can present as diminished ability to internally rotate the humerus. So the humerus may be externally rotated since they can no longer internally rotate or they have weakness there. It could present as diminished ability to extend and adduct the humerus. But with injury to either of the subscapular nerves, we are not going to see any loss of cutaneous sensation. So to figure out what muscles are innervated by the subscapular nerve, we have this image here, and we have a couple muscles that are going to internally rotate the humerus. So we can see here we have one nerve. This is the upper subscapular nerve right here, and that is innervating this muscle that is in the subscapular fossa. But then we have a second, the lower subscapular nerve right here. That is also innervating this muscle in the subscapular fossa. So the subscapularis muscle, it internally rotates the humerus, and it is innervated by both the upper and the lower subscapular nerves. And then our second muscle that we have here, it's a round muscle, and so we're going to call it the teres major, because teres means round, and it's the bigger of two round muscles. And the teres major, it is going to internally rotate the humerus, but also since it has this lower attachment, it is a little bit better able to adduct the humerus, and since it's originating more posteriorly, it will also help with extension. And we can see here when we look at the lower subscapular nerve, it is innervating teres major. So I've always remembered that because the teres major originates on the inferior angle of the scapula, the bottom of the scapula. So it makes sense if it's on the lower portion of the scapula that it's innervated by the lower subscapular nerve. All right, so moving on, let's talk about the thoracodorsal nerve. And this is the nerve, it's going to be coming off the posterior cord, and it's the one that is sandwiched between the upper and the lower subscapular nerve. So thoracodorsal nerve right there. Sometimes it's actually called the mid-subscapular nerve because it's in between those two. Injury to the thoracodorsal nerve can present as diminished ability to adduct, internally rotate, and extend the humerus. But again, like with a lot of the nerves we've already seen, we're not going to see any loss of cutaneous sensation. The thoracodorsal nerve is only going to innervate one muscle, and it has dorsal or dorsi in its name, and that is the latissimus dorsi muscle. So we can see that muscle here. Latissimus just means the broadest, dorsi means back, so it's the broadest muscle of the back. And you can see the thoracodorsal nerve here innervating it on its deep surface. The actions of latissimus dorsi, you can see that it would help to adduct as well as internally rotate the humerus. And then since it has a more posterior origin, it will also help to extend the humerus. Then again, that's innervated by the thoracodorsal nerve. All right, the next one on our list is the axillary nerve, and this one also is coming off the posterior cord, and we can see it right there. So again, if you use the mnemonic, you'll remember the posterior cord, those branches are the ultra, they kind of form that ultra trident, so UTLRA, or the Utler trident, but we've got the axillary nerve here coming off of the posterior cord. And the axillary nerve, on its pathway to innervate the muscles that it takes care of, it goes through this space right here. So we'll label, we've got the axillary nerve right here. And then this space, you'll see it has 4 sides. So we're going to call it the quadrangular space. So it's kind of between teres minor, the long head of triceps, teres major, and then just the medial border of the humerus. One other note about the axillary nerve is that it is wrapping around the surgical neck of the humerus. So a fracture to the surgical neck of the humerus can injure the axillary nerve. Injury to the axillary nerve will present as diminished ability to abduct the humerus, diminished ability to externally rotate the humerus, and this one actually does some cutaneous sensation to the lateral shoulder, so a patient would not be able to feel, or they would have some cutaneous sensation loss over that portion of skin for the lateral shoulder. To get these symptoms, we're going to have 2 muscles innervated by the axillary nerve. We can see them here. One is going to be the deltoid muscle, and that muscle, it basically does everything. The anterior fibers, which are pictured here, they help with humeral flexion and internal rotation. The more middle fibers, those are going to do the humerus abduction from 15 to 90 degrees, and then the posterior fibers are going to extend and externally rotate the humerus. And then the second muscle that's innervated by the axillary nerve is the teres minor muscle. And so we see a little bit of that guy right here. And that muscle is going to externally rotate the humerus. So it's one of the rotator cuff muscles. The way I've always remembered this, I feel like deltoid sounds like a name, and so does teres. So the axillary nerve innervates deltoid, and his wife, who's finer, teres minor. And to wrap things up, we're going to finish with the pectoral nerves. And so we have 2 pectoral nerves here. One is the lateral pectoral nerve. It gets its name because it's coming off of this portion of the brachial plexus, which is the lateral cord. And then the other pectoral nerve is the medial pectoral nerve. That gets its name because it's coming off of the medial cord of the brachial plexus. Injury to the pectoral nerves may present as diminished ability to adduct, internally rotate, and flex the humerus, and we're not going to see any loss of cutaneous sensation. There are 2 muscles innervated by the pectoral nerves, and if you had to name a muscle or muscles innervated by the pectoral nerves, you'd probably name them the pectoral muscles, which that's what we're going to see. So the first one we'll talk about is the pectoralis major muscle, and we can see that muscle here. It's kind of been cut away a little bit, but we can see it here off of the sternum and clavicle. The pectoralis major, it's going to internally rotate, adduct, and flex the humerus, and that is innervated by both the medial pectoral and lateral pectoral nerves. And we can see the medial pectoral nerve is here, so it's actually piercing pec minor. So medial pectoral pierces, or I think medial pectoral marches through pec minor to innervate pec major, and then the lateral pectoral nerve is right here. It's leaping over pec minor to just innervate pec major. And we'll throw on the next one, pectoralis minor. Its action is attaching to the coracoid process here, so it'll help to depress the scapula. And the pectoralis minor is only innervated by the medial pectoral nerve. So again, the medial pectoral nerve marches through minor to also innervate major. The lateral pectoral nerve leaps over minor to only innervate pec major. And that is it for the pectoral nerve. So let's do a review. And to do our review, we're going to go through a quick table of what we've gone over. So starting with the rotator cuff muscles, these muscles are grouped together because they all will do some sort of rotation for the most part, and they help to stabilize the humeral head in the glenoid socket. And so those muscles are the sits muscles, so supraspinatus and infraspinatus, innervated by the suprascapular nerve. Teres minor is done by the axillary nerve with deltoid, and then subscapularis is innervated by the upper subscapular and lower subscapular nerves. Next on our list, we did the intertubercular groove muscles, and one way you can remember these is it's 2 majors and a miss. So the majors are pectoralis major and teres major. Pec major is innervated by medial and lateral pectoral nerves. Teres major is done by the lower subscapular nerve, which makes sense because it's coming off of the lower part of the scapula, or the inferior angle. And then latissimus dorsi is innervated by the thoracodorsal nerve. These muscles are grouped together because they have an insertion on the intertubercular groove, and they also pretty much do the exact same action. So they're all doing humerus adduction and internal rotation, and then the muscle that's more anterior helps with flexion, the muscles more posterior help with extension. And then finally, we have these 2 other muscles. So pectoralis minor, which we talked about, is innervated by the medial pectoral nerve, depresses the scapula, and then deltoid is innervated by axillary nerve with teres minor, and it just does everything. And so that is it for this video on the innervation of the intertubercular groove muscles and the rotator cuff muscles.